can see a life together, standing by you, and I think I want to forever. And after all that's come and gone through all the years, I can't believe the moment's finally here. Hey, you never looked so beautiful. You're everything I've waited for, and so much more, standing right in front of me. And we can weather every high and low. If love is going where we go to have it hope forever, let's start our life together. Let's start our life together. Let's start our life together.
Welcome to the webinar, everyone, and thank you so much for joining us. I'm Adrian Sandler. I'm a developmental behavioral pediatrician, and I'm the executive director of the Center for Holistic Initiatives for Learning and Development, much more easily known as CHILD, here at the National University of Singapore. Our topic for discussion today is nurturing care for all young children, the promise, potential, and pitfalls of primary care. And we have a stellar international panel of guests today with expertise spanning research and policy and practice to share their perspectives and experience. So first, let me introduce Sharon Goldfelt. Hi, Sharon. Sharon is a pediatrician and public health physician at Royal Children's Hospital's Centre for Community Child Health in Melbourne, and theme director of population health at Murdoch Children's Research Institute. Sharon has a wealth of experience in state government as a senior policymaker in health and education, and has thought deeply and written with great clarity on what makes for a successful and equitable early child development service. So Sharon, thanks so much for joining us today.
Thanks so much, Adrian, for having me here. And I'm hoping you can all hear and see me okay from down under here in Melbourne, Australia. Here in Australia, we acknowledge the traditional owners of the land, and I'd like to do that here. So I'd like to acknowledge the traditional owners here, which is the Bunurong people of the Kulin Nation, and to pay my respects to elders past, present, and emerging, and any First Nations people anywhere across the world who might be watching here today. So I think this is such a fascinating topic, and I'm just going to say a couple of things. First of all, I just want to say there's a couple of words that you use that I think are going to be really pivotal to our discussion today. One is nurturing care, which already talks about this holistic view of children and child development. And the other is for every child, which is really about this idea of equity and universality. And I wonder if in doing that, we need to just think about a few things. Number one, we know that actually health services themselves actually contribute only about 10% of the differences in equity that we see in health inequity. So we have to be careful that we don't go, well, let's just do health services and we'll all feel good about it and the gap will close, because we know the social determinants play a huge role. And the question I think we need to ask ourselves is, what's the role of health services both in addressing these issues of inequities and child development and nurturing children, in both directly but also indirectly as a gateway to the social determinants? And if I might say, there's a couple of things I think are important for us to hold. One is the idea of the N of one. So, you know, I'm a practitioner, I'm a paediatrician like many online today. So I still see children, and the N of one and making a difference to that N of one, understanding the context of their life, that's still really important. But we know that that's not going to be enough. We also need to keep populations of children healthy. So today, I think we're going to kind of want to hold both things. How do we create health services, and particularly primary care, that can still do the best for the N of one, but also how do we make a difference to populations of children, and what is the role of universal or primary care in delivering on that? And so I've got 4 very quick opportunities. I promise you I'll be quick, Adrian. One is the opportunity for proportionate universalism. So making sure that whatever we're
Sharon,
delivering.
if you don't mind, Sharon, I'm going to introduce the others.
Okay.
And then with everybody present, I think at that point to come back to you and and get those points would be better.
I reckon I still had a minute of my 3 minutes, but I'll give it back to you, Adrian.
Okay, thank you very much. Well, that's I really do appreciate the introductory comments and the perspective, Sharon. I look forward to hearing more. And next, I'm delighted to introduce Abhirami Anatan, better known as Abby. Abby is a family physician and consultant at National University Polyclinics and the deputy head at Chua Chu Kang Polyclinic. And Abby has broad experience all the way from obstetrics and pediatrics right through to geriatrics, a leader here in educating young primary care docs and in primary care QI initiatives. So Abby brings to the panel a contextualized Singapore primary care perspective. So thanks for joining us, Abby. And
thank you, Adrian.
And next up, let me introduce Alan. Alan Mendelsohn. Alan is a professor in Department of Pediatrics and in the Department of Population Health at NYU School of Medicine in New York. Alan is a developmental behavioral pediatrician who has done groundbreaking work in designing and implementing primary care preventive interventions that really make a difference, and especially for low-income and at-risk populations. And these include the Reach Out and Read work and the work on the video interaction project. And so really delighted to have you join us today, Alan.
It's a pleasure to be here, and I look forward to today's discussion.
Thank you. And then also I'm delighted to introduce to you Henning Thiemeyer. Henning leads the Maternal and Child Health Center of Excellence at Harvard Chan School of Public Health. And Henning is a pediatric epidemiologist who does stellar research focused on child development and in particular in high-risk populations. Henning's work with GenR and other longitudinal cohorts, I think, shed some important light on some of the links between infant behavior and later important health and well-being outcomes that have important implications for prevention in primary care. So welcome, Henning. Good to see you again, and nice to have the panel convened for the purpose here. I just wanted to also mention that Child is very fortunate to have Henning and Alan and Sharon all part of our International Advisory Council. And both Henning and Alan also are visiting professors here at NUS. Let me just make a couple of housekeeping announcements. Please post your questions in the Q&A. The Q&A function will be on throughout the webinar, and we'll be able to see your questions. Although multitasking is not my forte, we will try to get to them. And if we don't, we will follow up with you after the webinar. And also to let you know that we will open a chat room near the end of the webinar for you to share your feedback and comments. That's really helpful to us. So to set up the discussion then, we are talking about primary care, the promise, potentials, and pitfalls of primary care. I mean, we all agree that a good start to life depends on the provision of nurturing care, good health, good nutrition, responsive caregiving, safety and security, opportunities for early learning. And we all agree that primary care, with its multiple prenatal and postnatal touch points for parents and infants and children, has a critical role to play. But the challenge is how. How can primary care really go beyond nutrition and immunizations and effectively support and promote nurturing care and optimal early child development? And I know that we really would need way more than an hour to do justice to the topic, but I'm going to return to you, Sharon, just to get your perspective initially for just a few minutes about what really resonates most with you, and perhaps highlight an aspect of your work that really sheds light on this. Thank you.
Thanks, Adrian. I completely jumped the gun, so apologies to my panelists. So I didn't read the memo correctly. I won't repeat everything I've just said, but I will just come back to this issue of holding both the N of one and how do we keep populations of children healthy, and the potential pivotal role, I think, of primary, I'm going to say primary / universal care, healthcare in that. So the 4 opportunities I'd like to put for us, maybe for discussion today, is number 1, the opportunity for equity, and that is to deliver primary care in a proportionate way. That is, what do all of the people need all of the time? What do some of the people need some of the time? And what do some of the people need all of the time in a proportionate system that's able to be able to deliver in that way? Because we know that when we deliver equally, we actually get unequal outcomes because we get disproportionate uptake by the middle class. The second opportunity is a practice opportunity. So this is a below the line opportunity, but how do we ask practitioners and professionals to actually ask a lot more about that holistic view of children and also the holistic view of their lives, so the social determinants. So we've got to get better at asking, and that is not a trivial pursuit. The third opportunity is to pay attention to equitable actual delivery of services. So what I mean by that is if we don't have an eye on equity from the beginning, we actually deliver inequitable services. So is there enough of it in terms of the population? Are these services any good, and do we know? And the third is, what's the sort of uptake? So what are our participation indicators that tell us, hey, we actually are getting universal outreach? So they're the kind of equity indicators. And the fourth is building the evidence. So I don't want to sit here and say, well, we've got it all worked out, and thank goodness we've got 3 international people here because we're definitely going to tell Singapore how to do it. But I do think building the evidence, the local evidence, and then sharing that is really important. So what works, what doesn't work, and how do we kind of know? You've got a beautiful cohort studies, you've got administrative data in Singapore. How are you going to know that you're actually starting to make a difference? So I might end there. That's the second half of my.
Thank you very much. And I think Sharon, it really sort of emphasizes the importance of data and evaluation. And I think that from what I understand, Victoria really has done exceptional work there. And so I look forward to learning more about that. I'd like to invite Abby to perhaps share some of your initial thoughts about this topic and maybe an aspect of your work that really speaks to the issue.
Thanks, Adrian. Thanks, Sharon. So probably I think Sharon has summarized with regards to what would be the essential outcomes of our topic, at least in this next 1 hour. Probably from my aspect, or rather in Singapore's mode of action with regards to childhood development, I would probably say that at least in the last one year or so, we definitely have increased the touch points with regards to child development screening for the children, at least for the children to be able to assess primary care services, both with regards to nursing as well as medical professionals. Therein lies the need for us to be able to inculcate and educate and empower our parents as well as their caregivers with regards to the necessities, the nutrition, the dentition, the screen time that is of rampant in this new era, especially with COVID pandemic, as well as we do see a lot of behavioral, issues that are also arising, probably because there is more awareness in this particular time and age. So that is something that we may want to also evaluate. And having multiple checkpoints actually does help us leverage more effectively with regards to promotion as well as supporting this optimal early childhood and development. So I would probably want to use this and see how we can then leverage and evaluate how we are able to share the equities that Sharon actually did bring it up. Because if we are going to be able to spread this message to everyone, then it doesn't become the same share of the pie. Some may need a bigger share of the pie and some may not. Therein then lies how do we incorporate our other stakeholders into this, and not just the primary care partners. Yeah, I'll probably stop here for now.
Thank you, Abby. Thank you. And as you spoke, hearts, rose from the bottom of my screen. I think that your comments really resonated with others who are tuning in. Alan, let's get your thoughts on this topic, and perhaps highlight something from your work that really sheds light.
I'll say that my thoughts about this come from both my background in research, but also very much from my background as a practitioner, which has been both in general pediatrics and in developmental behavioral pediatrics, so seeing kind of both sides in a certain way. And, in my experience as a general pediatrician, I spent a great deal of time, identifying families with challenges and children with developmental delays and referring them for services, sometimes successfully, sometimes not. And I think that what really began to draw me in this direction was really thinking about, well, can we do something that would represent primary prevention of problems before they emerge, and that's what really sort of drove me. The first work that I did in this area was related to the Reach Out and Read program. I can talk about that more later, but it sort of impressed me the degree to which one could have some benefit with a relatively low-touch intervention with provision of children's books and some guidance and modeling. Since then, I've given thought to other additional approaches to increase impacts. That includes Video Interaction Project, which Adrian, you had alluded to, which involves operationalizing or using video feedback in primary care, brief video recordings with real-time review to identify and reinforce strengths, and I can talk more about that later. Continuing on, I began to think about integrations and layering, both within primary care and across other settings, including in the community, including in home visiting. And I really very much agree with Sharon's point that we're not going to solve every problem in primary care, and need to think a lot about how to reach families in multiple settings and places. I guess I'll just kind of mention a few quick principles that have sort of resonated with me over this time. Again, one of them is just primary prevention. Can we prevent before problems emerge? A second is that in addition to identifying social determinants and ACEs, which is critically important, I think that there has been a lack of attention to the importance of promoting positive child experiences, and a new emphasis on early relational health, I think, is drawing many of us to think more in that direction. A third is, the need to think about using evidence-based strategies for both intervention and for engagement. And, that involves, from my perspective, providing books and providing developmentally appropriate toys to support parent-child interactions, engaging in strengths-based approaches that are non-stigmatizing, and engaging in strategies that are both health literacy appropriate and that are culturally aligned. A fourth area that I'd just like to mention is the recognition of interdependencies across domains. My perception is that there has been sort of siloed work thinking about cognitive and language development and aspects of school readiness on the one hand and social emotional development on the other. And I think for us to make a difference, we need to consider both. And then, as I had sort of alluded to before, last, I will just mention the need for working across platforms and sectors, integrating, layering, and I can give some examples of this, but I think it is critical for the purpose of addressing heterogeneity and risk, reaching families wherever they are, and delivering complementary messaging, and thereby hopefully increasing impacts.
Thanks, Alan. I think that the comments really kind of serve as a blueprint in some ways in sort of how to go about bringing positive change to systems. So appreciate those comments. Henning, I'd like to bring you into the conversation. Again, just your initial thoughts about the topic and what really kind of connects with you.
Yes, thank you. Thank you all. I wonder what the primary practitioner or the general practitioner in this audience will think. You might feel after these introductions a bit of, overwhelmed. At least that's, there is so much that primary practice can do, should reorganize. I like the systems approach of Sharon very much. As a public health person, I really endorse that. And yet, in my work evaluating CDC, so it was the American Center for Disease Control programs for practitioners, we see how hard it is to implement programs that really address inequities. They're often lost, quite hopeless when they encounter inequities due to poverty, due to race, due to homelessness. What can the primary practitioner do? So I would like to emphasize how much what really resonates with me is the access to healthcare. So I think we should stand still and discuss that. That is locally specific for Singapore. So I really look at Amy, because I think in most countries that is, even in primary healthcare, a problem. And, you can think of the wonderful NHS or whatever, and it's still not equitable. The other thing I would like to take up, so I'm just resonating what Alan said. Again, a lot that overwhelms but a lot of very good things. My own work is very much focused on what preventive, specific and general preventive measures can the primary practitioner do or should do more on. And I think he alluded a lot on the cognitive, social, emotional. I think we could discuss that, but there are also other areas where I think primary and secondary prevention even could be better in the typical practice. And the last thing I would bring, so it's three things: access, specific measures of prevention. I'd like to ask all of us, where do you think can be gains, perhaps one hobby horse of each of us? And the third thing is to engage the family as a mental health interested person. And that's also been mentioned. I heard it mentioned several times, but it is a big challenge for primary care physicians to engage the parents. And I will say that fathers hardly ever turn up. Secondly, I will say that if mothers turn up, they really don't want to be they don't want to be treated. They bring their sick child. And if you tell them there's also a problem elsewhere, that can be quite a challenge. So how to engage the family meaningful, and also point at the fact that in Singapore, the family is complexer than in many other countries, because the role of grandparents is often much more fundamental, and there's domestic carers, and that poses unique challenges to a primary care physician. So those are my thoughts.
Thank you very much, Henning. Yes, and I would like to follow up in just a little while about the specific sort of primary and secondary prevention. Maybe others on the panel would like to pick up on that discussion too. Just wanted to remind the audience that the Q&A function is open, so please post your questions, and we will be checking on those periodically. Yes, so let me go back to you, Sharon. You spoke about, the important elements for an equitable, universal early child development service, and about how, from a systems approach, we can sort of try to have primary care integrate a focus on health and nutrition with the broader goals of promoting early child development. And you mentioned the phrase above the line and below the line. I wonder if you could talk just a little more about the below the line issues that sometimes serve as challenges and obstacles that we need to be able to address in order to help primary care docs and other professionals to help them to keep these things in mind.
Absolutely, and this is a kind of segue to Alan as well, because what we're both talking about, I think, are kind of primary care practitioners working as an island probably doesn't work very well for children. So how do you get purposeful integration of primary care with the other sorts of sectors, services, etc., that we know are important for children? And that's the kind of what I'm talking about. There's the above the line integrated system sort of work that needs to be thought about. But actually below the line, even if you co-locate or whatever you do, getting and asking people to work differently is not trivial. And just because you say so doesn't mean people will work differently. So to me, and we've been working on this in particular in two ways. One is that we have an integrated hub in a relatively low income area in Melbourne where I live. And we've been working with just simple things like, how do you get practitioners to ask families about the context of their life, the challenges that they have in their life, and as a practitioner feel comfortable to do that and know what to do next. How do we get practitioners talking to each other so they can share the common problems and form a community of practice so they know how to think about referring to each other and generally being able to support families? Just those sorts of things are incredibly difficult. And we've done a sustained nurse home visiting trial in Australia, and one of the greatest challenges was working with those nurses so they felt comfortable working with families and not feeling they had to drown with those families. One of the biggest barriers for practitioners about asking those questions is a fear of what do I do next, or that I'll go down that rabbit hole with that family and not be able to not know what to do next. So being able to hold a family but still listen to them, all of that relational stuff, that's hard. And people need to be supported to do that. And I always fear that this is your point, Henning, that we kind of sit here and kind of pontificate about what practitioners might do, but it's really hard work and it needs support. And the final thing I'll say is, I think we're thinking more and more about what is the kind of glue, i.e. what is the non-clinical support that is needed for a system to work well so that the practitioners are actually supported to do what they're doing. And all of that stuff of how do you support people to ask those questions? How do you set up quality improvement cycles so they know how to do it well? How do you set up communities of practice? All of that doesn't just happen off the side of someone's desk. They really need the support processes and people around them. And I always fear that we just expect a lot out of clinicians, and yet we don't always provide the support they need.
Very, very helpful, Sharon. And I would like to have Abby kind of pick up on the thoughts there about what some of the challenges are, Abby, in your experience in the primary care setting in Singapore, in setting up that kind of the communities of practice and establishing among the practitioners the kind of below the line skills and supports that are needed in order to do so effectively.
Okay, so I think with regards to system-based practice itself, I would probably say it's a boon and a bane. It can be a blessing as well as not. Because if you think about it, we are very much, even though we are a small city, but an important city, I suppose, we do have geographical, landmarkings, and we do have system-based practices, which because of PDPA restrictions and all that, we aren't able to share our notes with, let's say, my co-practitioner across another cluster. So that sort of limits our child's access to another cluster. So that puts us, or rather puts the family at a strain as well. So I would say probably in the long run, to see how we can best integrate such that the system-based practice itself doesn't become a limitation, and actually it gives us a blessing. It becomes a blessing where it actually opens up access, where the child is able to permeate through the system, permeate through the clusters without having any mishaps, without falling through the loop, like a Swiss cheese model in a sense. So what I have found, let's say I found an abnormality, or I've actually referred this child on, and suppose because of time constraints, commitments from parents or caregivers, and the child is actually not able to present themselves to the pediatric component, right? The pediatrician. Then at least if, let's say, my co-practitioner across the cluster is able to pick it up because of the system integration, then at least they will be able to ask, you were supposed to be referred, did you go and see so and so? If not, then probably we should evaluate if there is a need to further pursue this. And then at least we handhold the family rather than picking this up after many, many years, when it becomes a problem and actually it has caused or contributed to a delay in the care for the child and family. So I would probably think we may need to find, I mean, we're still in the infancy stage. We are definitely developing towards it. But it's just, integrating all the stakeholders in charge. It's not just the medical professionals. It's not just going to be the nursing professionals. It's going to be our IT guys. It's going to be healthcare policies. It's going to be higher up, actually. Hopefully I'm not in trouble for saying this, but at least, we integrate together for the best interest of the child and the family. Because what we see now is where I have probably seen this child, let's say at 1 month or 3 months, or even 6 months, 12 months, when we did a project on, MCHR screening for autism spectrum disorders. I've seen a child put specifically and referred a child on. But sadly, because of family commitments or just unawareness that this is an urgent problem, the child was not referred on. And probably, because of the system integration not being there fully, the other professional is unable to see that the child was actually referred. And hence, at 3 years old, when the child comes in, the parents are unable to cope with behavioral tantrums and becoming more disruptive in schools, unable to concentrate, and unable to have a good language or speech. So to me is where I could have done something, or the child could have benefited from early interventions much, much earlier when we referred on. I think these are things that we may want to look into the future, even in Singapore's context.
I think that really speaks to the importance of intervening early and upstream. A question from E. Hyok Hua about whether mental health assessment or mental health resources are available. And I think, Sharon, you also mentioned, the importance of having an integrated approach. I know in my own clinical practice, having an integrated team-based approach to care was so important. But Abby, I don't know if you wanted to just expand on that particular question about the presence of mental health assessment and mental health services in the primary care context in Singapore.
I think it's still, again, in the infancy stage where we are still, getting recruitments for our psychologists, definitely for psychiatric care or even child development unit, specifically for underage children for, when they are prior to hitting primary schools. I think the resources are still limited. Even if there are resources, I think the time limit is an issue. The turnaround time for a child to be seen at our secondary partners can vary from about 2 to 3 months. Within which, so what we do in the primary care is at least to try and see how we can patch them within the 3 months, at least inculcate the stimulation of activities, reduce the screen time as much as possible, especially with, I think someone actually brought up the point about domestic helpers, nannies and nannies and other than parents as main caregivers. Screen time has actually increased. So exposure of children towards gadgets and TVs are actually more rampant. So how do we actually reduce that and promote outdoor play? That is something that we can probably try and bridge in 3 months or 4 months prior to them actually still showing up at the necessary referrals, be it psychologist or child development pediatrician. So that's probably what I would say.
Thank you, Abby. Alan, let me ask you to go back to one of the things you mentioned earlier, just about primary prevention and how primary care pediatric services have evolved. How maybe with your reach out and read experience, how this has really helped to reach those harder to reach families and also benefited providers in those the kind of below the line skills that we were talking about earlier.
Thank you, Adrian. That's a great question. So a couple of quick comments. First of all, I would say from the perspective of primary prevention, the data that has really impressed me is the data showing the degree to which supporting positive child experiences can buffer the effect of ACEs on the one hand, and on the other are critically important regardless of whether ACEs are present, universally important potentially for all families. What I'll say about ReachN and Read is that ReachN and Read is sort of a poster child program in this this regard. By supporting reading aloud as an experience that can be a very positive experience for parents and children together. I will also say that from the perspective of providers, ReachN and Read has proven to help providers to feel, to be able to perceive their importance in supporting, early child development and being able to engage in prevention before the onset of problems, just like they do with, through immunizations, right? I will say that, that's probably what I want to say about that. I will say that, maybe that's enough for now. I know what I wanted to say. Sorry. What I wanted to say was that what is really reinforcing, to parents and to providers and to parents are relationships. And so, programs like ReachN and Read are relationship building for parents, for providers and parents, and in building those trusting relationships, thereby support parents then engaging in activities that are being promoted as primary prevention. So just wanted to say that.
Yeah, no, I really appreciate the comments about positive early experience, about supporting responsive caregiving, and the potential effects that has in buffering in children who are at risk.
Henny, can I just follow up just quickly, because I know you want to go to Henny, but just to reinforce one of the opportunities with primary care or universal care, well childcare, whatever, however we're going to talk about it, is this kind of continual relationship. So it's not, I've got a really bad thing and I'm going to go see a specialist. It's actually this ongoing trusted relationship that you build with a family, so that maybe they won't talk about family violence the first time, but as they build the relationship, they might talk about that, or maybe they won't take on board something you've said. So you get both the opportunity for the continuing the relationship, and Alan's completely right, it's all about that relationship and relational practice. But the other is those teachable moments that come along with it as well as children's development continues. So I think that's really the cornerstone and the benefit. We talked about the benefits and the pitfalls. The absolute promise of primary care is the building of that relationship over time and not as a one-off.
Yeah. And I'd like to just sort of follow up on that and ask you, Henning, in terms of opportunities for early secondary prevention, and knowing from the associations between early child or infant behavior and later problematic outcomes, what are some of the real take-home points for how to intervene early, or how to provide guidance early on in order to prevent those aspects of early child behavior becoming more problematic in the future?
I think there's a few themes, or probably many themes. One of them that's been in the Q&A and has been touched upon, and is also one of my areas of interest, is the mental health, and I'll go into that. Secondary prevention would mean that the child already has some known problems, and it is now the goal to prevent that they become more severe, or actually that they remit. And I would like to point out that in children, mental health problems are in a way more diffuse. We tend to take picky eating or eating problems as part of mental health, if you want. You could say that's a dietary eating behavior problem. Sleeping problems should also be considered among these, and regulation problems. So they've got a very broad domain and many problems. If you take the encounters in primary or child primary healthcare, this is a lot of the problems. I think the question was a bit, should we systematically screen? It's actually a bit debated which screener, how to do it. There are some that work, but it's actually quite not so easy. But I think in secondary prevention, you would think of the common disorders, for example, ADHD or anxiety disorders in children, withdrawn, anxious children. Both of these conditions, I would like to point out, can be treated very well if needed, with psychotherapy or medication, but in very early phases, certainly the anxiety disorders, just with small behavioral tips and interventions, can often be prevented from escalating. I don't want to go much further. As other things is eating, picky eating, which is often, not at all such a problem as it is considered, and very few children go on to develop problems. That has been shown. So it's one thing which is very interesting, that where often the parents are much more concerned than they need be. That is also something. Not every problem is that. And then I want to go further in the prevention, the secondary prevention, my hobby, to say that if a child has, let's say, reasonably disruptive oppositional behavior or very strong anxious behavior, you have a bit about a more than 50% chance that one of the parents has a reasonably severe mental health disorder, because it's not uncommon anyway. And in these children, it's more common. And sometimes even the child can contribute to that. So I think primary prevention is mandatory to address that. So if your mother comes, you have to ask about her problems, or you ask even about the partner's problems, which is not always easy, but very important. And the other aspect, and then I'll stop. In these families, often there's conflict. We have seen that family conflict is one of the main risk factors for the ACEs that Alan mentions, but also for the poor outcome of these disorders. So I think one should be open to address family conflict, and that is quite a skill, because the mother comes again with a child with anxious problems, and you then talk about the conflict in the family. But I do think it is that. And then I think Amy pointed out the importance that you can collaborate with psychiatric nurses, mental health nurses, or psychologists is another thing. But often, good advice can be a good secondary prevention of behavioral regulation. For example, she's mentioned screen time. Motor development helps. So there are programs for that, but also good clinical practice. That's one aspect. Another one is diet, and we could open another Pandora's box. I don't know if you want to do that. I'll just pass back. So I think there's a lot to be gained in diet in Singapore, as in Australia, as in the US. To take it away from mental health, we see that. And another one is asthma, where we have, quite easy preventions from pets, and somebody with an expertise would give preventive measures there. But I'll stop.
Adrian, if I could add something.
Yes, please do.
A comment on Henning. I think you're really important comments in so many ways. One thing I want to note, and it's part of the nurturing framework, right? The nurturing framework is not just development, right? It's also growth. And when one thinks about health, and it's intertwined, they're part of the same thing. It's not just a matter of, when one thinks about, let's go back to this idea of primary prevention, returning to that, and positive child experiences, supporting children's growth and development represents supporting the critical outcomes of early childhood, and they go together. Responsive parenting includes not just being responsive to the child's vocalizations and responsive to the child's emotional and verbal cues. It's also responsive to the child's hunger cues, let's say, or need for eating. And in fact, the same kinds of support I think can very much work together. So I just wanted to kind of add that.
Thank you. There are a lot of a lot of discussion in the Q&A about layering and the importance of layering of supports when it comes to sort of achieving equity. And I wonder if we could discuss how to integrate both universal approaches for all in this effort to improve primary prevention with the layering of additional targeted supports. I think that some of you have had experiences of doing this in different communities, and I would like to just get perspective from you on that big challenge.
If I can jump in for a moment, because I think it's important that we kind of get some clarity on a kind of proportionate universal base versus secondary care, because I think they're two different things. So one might be, and they're both important. So one might be, how do you set up secondary care to meet the children who have got additional needs or diagnoses that require additional supports, or, in Australia, paediatricians actually provide that secondary care, for example. But that's quite different to how do you deliver a proportionate universal or primary care service. It's actually designed to think about what do all children, so that the stuff that everyone's been talking about, this primary prevention, that what do all families need all of the time, no matter who they are. So because often families who are living in university, we actually jump that step. We often go, right, let's go drive those ambulances to the bottom of the cliff and just forget that there was a fence at the top of the cliff you could have ever done with them. So I think that kind of universal touch point of everybody all of the time is really important. And it goes to the issues of reach, because if we're not reaching everybody, we're not doing universal. And it goes to the idea that universal touch actually means universal benefit. We're not just touching people because that's kind of a KPI. It's because there's a benefit from doing that, which is around primary prevention. And then it's like, what do some of the people need some of the time? So what's the ability? And this, Abby, you'll be really kind of keen on thinking through this and have thought through this, I'm sure, which is what's the elasticity in the system that allows us to deal with problems as they emerge? Because people don't, like, you get divorced, or a child gets sick, or you move house, or, like, things happen in people's lives that change things over time. And how do you systematically elicit for some of those things? And that's where we've talked about, systematic questioning or some screening. We can have a whole debate about screening that actually allows you to go, who's going to need some extra help here, still within the same service. And then this is where sustained nurse home visiting things come in. What do some of the families need identified very early? That means the standard service is not going to be enough and they need something all of the time. And that's why sustained nurse home visiting is so great. It's a preventive service. It's identifying families in pregnancy and saying, what do you need? That's still the same stuff that everyone's getting. It's still developmental promotion. It's still all the things everybody else is getting, but you need it delivered in such a way, intensity and methodology, like in the home, that's actually going to truly be about equity, which is delivering people what they need in the form that they need it. And that's still all primary universal care. That's not secondary care. And I think it's important to unpack those two things so that targeted doesn't look like it's some other service.
Yeah. Alan, I think you also have had experience in designing that kind of proportional universalism that Sharon was describing.
Yes, I would love to comment on that. It's tricky in some ways, because one of the biggest challenges is in engaging families. And, my take on it is that we're often doing this backwards. Where we, as, the people who supposedly are the experts, are telling families, oh, you need to do this and you need to do that. And at some level, we're doing it backwards, because in the end, all families share very similar goals. And I think this is true for every family. They want their child to be healthy, and they want their child to develop and behave like other children and be, successful in school and in their lives. And so getting back to this idea of proportionate universalism, it is tricky, because when we tell families, oh, you have a problem, we have to do something very specific for you. that may not be the best way to engage families broadly. And so there is something to be said for universalism, where, programs are at least offered to everybody, even if we know that some of the families are going to benefit more than others, so as to make programs non-stigmatizing, and so as to, in that sense, enhance engagement. So that's the first thing I just wanted to say, at least from my own experience. The second, in addressing, Adrian, the direct question around layering and integration, I've had experience with a couple of different models, both within primary care and across settings and communities. So an example of a model that I've worked on is something called Smart Beginnings, which delivers, or at least offers, Video Interaction Project, the program I mentioned that has video feedback with families around laying and reading, which is offered in principle to all families. And then as families, and then for families for whom either pre-existing or emergent significant challenges are identified, those families are then referred for a more intensive and clinically oriented home visiting program, which in the United States is family checkup. What's nice about this is that everyone is engaged, in the universal program. And what our data has shown is that engagement in the universal program then potentiates engagement in the targeted program for those families who are receiving it. So just to give kind of one sort of example like that. Smart Beginnings, I'll just add one other thing and then I'll stop. Smart Beginnings has been kind of implemented in something called the Pittsburgh study. And the Pittsburgh study is a misnomer. It's a population level attempt to engage families. And what is really neat about it is that in the context of some risk stratification that takes place, families are offered a menu of services. So again, it gets back to the idea of, we're not going to tell you what to do. We're going to give you choices, and we're going to try to find the services that you think best meet your needs. So I just wanted to give that as an example too. Thank you.
Yeah, thanks. And in all of this discussion, what seems to be really central is the family as the focus. We're not just dealing with child behavior sort of in a vacuum. And so when it comes to the risk assessment that you mentioned there, that is assessing family risk. And when it comes to layering supports and services, again, or integrating across silos, the focus is on supporting families. You've both raised, others have, I think we've all spoken just a little today about home visiting, and I wanted to pick up on that. How do you assure quality in home visiting programs? How do you sustain home visiting programs?
Feel I'd like to really pop in here, given that we've done it in Australia, and then others will have a view as well. And of course, we all have different systems. So I guess that's the other thing, that I think the US healthcare system and the Australian healthcare system are pretty different. I think Singapore sits somewhere in the middle. So we've been running this out now as a sustained nurse home visiting trial, and then it's been scaling across Australia. It's called Right at Home, or MESH. And I think there's three probably things that are really important. Number one, you're absolutely right. If we're not doing quality, then we may as well all go home. So fidelity to the program is really, really important. And it's not fidelity to the program from a tick box point of view, but it's fidelity to the program in the relational practice that the nurses are doing with the families. That's the absolute cornerstone. So as part of that, there is surveys that are done regularly with the families to say, how are you experiencing this? There is a practitioner support for the nurses. So they're actually being supported. So there's everything that wraps around for a higher quality service to know it is actually being implemented with fidelity. And the other part of the quality piece that people sometimes don't realise is the co-design and implementation. So writing in with a program that isn't co-designed with the end users, and I don't mean co-designing the fundamentals of the program that work. That's not what it's about. But co-designing it so the discussions the families and the nurses are having together makes sense for that population, co-designing how to implement it in a way that makes sense. That is part of the quality, because it's much more sustainable to embed something that makes sense for the population than to just roll in some research program and go, oh, here, that worked in Melbourne, so surely it's going to work in Singapore. We know that doesn't work. So but it's perfectly sustainable, but it's not perfectly sustainable without supports around it to make sure that the quality is sustained, because there is always professional drift. And Alan's done other stuff, as well.
Yeah. Alan, do you want to go?
No, go ahead, Henning.
Go ahead, Henning.
First, I want to point out that home visiting comes in different brands and formulations and forms. So there's universal home visiting for children and families. There's targeted home visiting. And different countries have tried different models. I think one of the oldest models is the Danish universal home visiting, highly intensive. Australia's, I'm not so familiar. The UK has a system. The US has 19 different approved home visiting programs for children with different names, different targets, different things. I'd like to point out that there are a few problems. Many of them have not been really rigorously evaluated. Australia is doing that different, but Danish couldn't even evaluate it because they've got it since the 1950s, and then that was before they were evaluated. So you can't ask them to stop with something that's so popular. But in the US, there's fidelity is sometimes a problem. The efficacy is also what we see, for example, if we've evaluated home visiting programs that have been running for a while. I've done that in Colorado, in Rhode Island, and Mississippi. You see that the response rates are below 50% in the US, whereas they are in other countries, they're 90, 100%. So what I'm trying to say is that Singapore will have to make their own experiences, as Sharon really pointed out. You have to make it highly, it's a big challenge to do universal home visiting programs, and the efficacy is, I would like to debate. You agree? You think it's brilliant, but I think it's quite.
No, I agree with you. I don't think there is any evidence for universal.
Oh, I'm so happy, because I was thinking I got my homework right. Yeah, no, we agree here.
No, I think for targeted there is, and that's what we've been doing, and that's what others have done. But there really isn't. I mean, there's probably evidence for some sort of universal touch point for families, or maybe as a home visit, but that's a strategic decision as opposed to an evidence. But sustained universal, I think. That, I wouldn't say, that's where I wouldn't put my money.
No, then we have something which we can, I don't know, unless Alan disagrees, I would fully agree. I think there's evidence for targeted, but then it's really well targeted, high risk families. And then you must make sure, for example, in the US that, how can I say it, that the people who do the home visits look like the people who receive them. We've seen that go wrong in Mississippi, big scale.
Sorry if I
go ahead.
Oh, yeah, sorry, if I may just jump in. I think what we are doing, we are basically more doing towards preschoolers, where the children are actually identified in the below 20% income by the government. So at least that is the targeted population for us to intervene. And usually our community pediatricians would probably go in to evaluate if there are any problems in the first place. So that is where the primary prevention comes in. From community pediatricians themselves. And if at all there are problems, then how do we actually curb them or limit them from becoming even bigger? So that's where the secondary prevention then arises. So therein, that will have its own hassle where, the cost rises, the need for referrals rises and all that. So that's probably where the primary care practitioners will have to come in. But at this point, it is very much targeted towards preschoolers who have already been identified. With regards to home visits, I don't think we have actually touched that domain yet. I mean, it's definitely a domain that we can potentially look at. If not for primary care physicians or nurses, actually the allied health, so the social workers, the psychologists, definitely we do have this group of people called family service centers, which is mainly run by social workers. And they do touch points with regards to home visits. And if need be, they are welcome to definitely liaise with primary care physicians, or primary care model is definitely available for them to touch base with. Yeah.
Thank you, Abby. Alan, any brief comment, because we're getting towards the end of our hour?
Yeah, no, I'll just generally be in agreement. I think that where the home visiting data is strong is around targeted delivery to families with risks. And I will also completely agree that maybe the one place where universal may be the way to go is a single universal touch point following birth, or this kind of approach.
Yes.
And I'll leave it at that because we're coming to
Okay,
that.
well, let me just ask the four of you if there's any important issue that you wanted to just touch on to add to the conversation. This would be the time to do it, but otherwise I think we will be wrapping up in just a minute or two.
I wanted to add just one quick thing, which is that I just wanted to emphasize this. Families have comparable goals, and all of our programs, all of our strategies have been developed in very specific places and settings, and yet the goals align with those of parents. And I think that there's a great deal of potential for us to do a lot of good.
Probably if I may just jump in again,
Yes, of course,
1
Abby.
hour is definitely not enough for this topic. It's amazing that we are able to share promises and potentials in this domain, but I think we've forgotten about our pitfalls. And if we can strengthen these pitfalls, definitely they will be honed towards our strengths. So pitfalls in the sense, sustainability of this home visits across multiple generations, time constraints in terms of our own. How do we actually do all these child development screenings with the need for educating or empowering our parents within the constraint of 10-15 minutes in a primary care focus? Not sure if you all share the same thoughts. With Singapore's demographics, we do have cultural differences. So how do we actually marry our cultural differences with our strengths, and how do we hone that as well? The other thing would be, how do we prevent burnout and stress in our caregivers, our own primary care providers, as well as when we refer to pediatricians and all that. So how do we actually prevent this particular topic in that sense? And of course, the last part would be, how do we upskill our own physicians? How do we, instead of just staying as an MBBS trained doctors, do we want them to be equipped further in this particular domain? So we do have a graduate diploma in childhood and adolescent health in Singapore. We do try and upskill them at least they are able to know what are the next goals of care that we can render, rather than what we've actually studied in medical school.
Thank you, Abby. And I think that those kinds of practical challenges should be the topic of another hour's conversation next time. So terrific conversation, highlighting great potential and clearly some pitfalls and challenges. If you enjoyed the webinar, I invite you to go to the website at thechild.sg. You'll find previous webinars there in the series, some information about upcoming webinars, along with Child's Evidence Insights and some information about ongoing work at Child. So just to say, the chat room is open, so your feedback and comments are really important to us. And big thank you to all four of our guests. Thank you all for joining us for this webinar.
Look in your eyes, and I can see a life together. Standing by you, and I think I want to forever. And after all that's come and gone through all the years, I can't believe the moment's fine.